Aneesh Garg, another great friend of mine. He was also a couple years ahead of Cleo and I at Andrews in Birmingham. And
I told him last night that if I knew these two were going to be the fellows, I would have deferred for 2 years so I could hang out with them more. So.
But a worldwide, maybe universe-wide expert in shockwave and EMTT.
We try to set the bar very low, so nobody gets disappointed. All right, let me see. So, thanks. So if you guys don't know, it's Sharon's birthday. So when you see her, just walk by. I think it's on Tuesday, actually, is her birthday. But just when you see her, just say happy birthday to her, please. She would love it, and she'll probably give you a big hug. All right, so how many people have heard of Shockwave? How many people have used Shockwave? How many people know the difference between radial and focused? All right, we're going to get into... How many of you know what EMTT is? Nobody. Is that right? Nobody? All right, cool. We're going to learn some stuff here. Because that actually works really well in nerve. And how many people do spine here? Yeah? So EMTT and Shockwave, there are some things you can do from a spine standpoint. It's pretty cool. All right. I have a non-surgical sports practice in Boulder, Colorado. These are just, again, my clinical experience. So off-label usage, but this is really meant to spur discussion and talk about some things. So objectives, we're going to learn about EMTT, decision-making process, and again, this can help in post-surgery recovery. How many people see people post-surgically? You? Yeah? Okay. I think we have a lot of shoulder problems here because nobody raises their hand very high. So it's just me. Just raise your hand so I can see it, please. All right, so this is a background. I used to work, so Clark recognized me. He and I were colleagues in, Cleo, I think I see what you're saying. So I used to, out of fellowship, so I went to Andrews before these guys, and after that I went to Chicago, worked inside an orthopedic surgery practice, built that non-surgical component for about close to 5 years, and then got recruited to Nashville to do the same thing, and then I quickly sort of realized being inside an orthopedic surgery practice is not the best place for me. I was getting held back. Because there are things that we can do that can negate the need for surgery, and if your primary business model is surgery, then they get their feelings hurt. Okay. I'm also one of the national team doctors for USA Hockey and US Soccer, so I travel with them when they need me. And just background, so med school in Arizona, I did my residency at Yale, so just a bunch of background stuff. What we're building in Boulder. So this is my office. This is actually synthetic ice on the left, so you can actually skate on it. There's the turf. We've lifted the ice because we didn't use it as much, so we had like a new custom turf down. This is the view of our office. So we designed this to look and feel what it is. It's a bougie, high-end sports medicine. Okay, this is probably the most important thing. Build relationships first, have a really good understanding of why you're doing what you're doing, and then you take care of people. I can't tell you how many times people are like, I don't know what to do. I hear about PRP, I don't know how to make heads or tails of it. You asked a great question about all these people that are saying that they do PRP, how do I know which one's for me? Just explain to them. This is why I said Jeff's lecture was so vitally important. If you're able to get a really good understanding and be able to explain it at a 5th grade reading level, I teach at a 5th grade reading level. I want everybody to be on the same page. And if they want to ask more, then they ask more. Can I write some academic, esoteric thing? Sure, but that's not the point. I'm trying to make sure that your point's understood. Is that fair? Fair? Right? Okay, so the big thing is give them options and then talk about the individual situation. I hand this out to everybody. His name is Carl. We draw on him and say, look, here's where your injury is. Here's what I think we can do about it. And I give him options. Is this a pointer here? Please? Oh, okay. Forget it. That's fine. So we talk about this. We kind of draw, hey, it could be a hip problem that's recruiting your low back. It could be an SI issue. This is why you're having leg pain. We kind of draw this out. You've got increased pain, you stop using certain muscles, you get weaker. We're going to do something here at Dynamic Athlete and then decrease pain by using it more and getting stronger. That's the ultimate goal. Then we kind of make this wheel of options and we go through pros and cons of it. Then they take it home and I say, put it on your fridge. I want you looking at it all the time. This is helpful because then what it feels like, you're customizing a plan for them. So this is just some picture of doing that. All right.
You hold down the long button, big button, middle
Yep.
button. That should, yeah, hold that down.
Oh, that's all right. I'll just point to it. Thanks. What is EMTT and Shockwave? This is what I draw out for people. What is nerve pain? It's electricity. So, a big old magnet should probably help in an electrical field. If you get so I kind of explained this, where if in a normal cell, the ion channels are lined up properly, plus on one side, minus on one side, there's a free flow of nutrients in and toxins out. When you're injured, they get distorted. So what does that mean? Less flow in, less flow out. So you're in this chronically injured state. What does EMTT do? We try to get you from that state to the other side. I had a surgeon on Monday from England who had a video call with me, first time that's ever happened. And he was like, well, this doesn't make sense. Like if you polarize one side, then the other side is going to be sort of, the pluses are going to be on the inside. What is it? And I go, okay, great. Now let's have a discussion about efflux and influx. That's what we're trying to do. So through the cell, it doesn't matter. As long as we're able to calibrate it, that's how it tends to work. It creates a better healing environment for what you're going to do further. This is why we use EMTT before we use the shockwave. Focused shockwave. Questions on that? Oh gosh. Questions on that? Does this make sense? I don't hear anything, so it doesn't make sense apparently. Does it make sense?
Makes sense.
Great. Okay. So focused shockwave, what is it? It's actually high intensity sound waves, acoustic waves that target injured cells. I draw it like this and I say, look, it bypasses normal cells, you don't feel anything, and then when you hit the spot, you're like, yep, that's where it is. That's where I feel it. That's how you know. And from an exam standpoint, we do the exam, we do an ultrasound, and I look at it and I go, yep, that's where it is, and then we use the shockwave machine, and we're like, yep, there it is, another confirmatory. So we hunt for diagnosis. That's really the big thing here. This is helpful. I kind of make this akin to dry regenerative medicine. Why? Because it increases cell proliferation, and it increases blood flow in poorly vascularized areas. Questions on focused shockwave? Okay. I don't really get into radial. Radial's a high-powered massage gun that works superficially, is how I use it. So the focus is really the workhorse more than anything else out of the three. Well, I shouldn't say that because I use the EMTT. So EMTT and shockwave, focus. When I say shockwave, it's focused. There's a big misnomer that radial is actually shockwave. There's a movement to call it radial pressure wave, focused shockwave, and EMTT. Three separate things. So when somebody came to me and said, oh, I had shockwave done, I go, wait a minute. Was it radial or focused? So they were like, well, I don't know. I was like, okay, did it hurt when it was on the bones? I was like, yeah, it hurt. It's probably the radial. So those are the things. So people that have only radial and claimed it for it to be shockwave, that's not really true. And they use it in a way that the focus should be used. So when shockwave's not enough, then what do you do? And that's kind of what we look at, PRP, adipose, and marrow. And this is sort of how we go through and from a decision-making standpoint. When I asked about who uses adipose, not very many people do. The reason we use it is if there's a rotator cuff tear, we use it. I use it in arthritis. It does really well in combination. So there's a lot of applications. And I think if you're not doing adipose, which is more new, a lot of people sort of go from PRP to bone marrow, and then adipose is sort of the last step here into this, in this sort of confluence of options. So the fact that you guys are here and we'll be able to practice a lot of this stuff, it's really good, because I mean, I think there's technical nuance to it that if you just practice and understand again why you're doing what you're doing, it's super important, and we'll kind of go from there. So how do I think about things? What do they have? Why do they have it? What's been done? We see a ton of second, third, fourth opinions in our office. Was it sufficient in time, quality, or quantity? We talk about PRP. You guys know now all PRP is not the same, yes? Yes?
Yes.
Okay. So I would venture to say not all Shockwave is the same. Same premise, right? And so who did it? Again, what's their protocol? We've had somebody had PRP and was out jogging 2 weeks later. And they come and they go, PRP didn't work for me. Do you think it's a PRP that didn't work? Potentially, but not the post is the problem, right? Like, you're gonna let somebody go play lacrosse 2 weeks after they had a PRP injection in their patella tendon? No way. Right? So when they come in and they say PRP didn't work for me, these are some of the things you gotta find out. What type of athlete? What are we trying to get them ready for? I always ask, what are we trying to get you ready for? Why are you here? Because the option, if you guys remember, do nothing. You can live with it. Right? Our very first procedure that we did in Colorado when our space is getting built out, we were in temporary space. A woman was 68 years old. She had patellar tendinopathy. I said, I think you need, I think this is what we would do. We would do PRP, and this is how we go about it. She's like, great, let's do it. And I go, yeah, but like, we don't have our space yet. And she's like, do you have everything you need? And I said, yeah, it's here. She said, gardening season's coming up. I don't want to miss it. That's what's important to her. There's a sign in our office, everybody's an athlete here. Actually, it's everybody's a dynamic athlete here. But no matter the age, skill, or activity level. So if you treat everybody in that regard, then again, a lot of this is about buy-in. Okay, common reasons for why we're using some of the biologics along with, from a Shockwave standpoint, chronic ligament tear. You have the chronic tendinopathy or arthritis that's not progressing with EMTT and Shockwave alone. Failed previous EMTT and Shockwave without orthobiologics is why you would add orthobiologics on top of it. Let's go through some examples. A 28-year-old, so questions so far before we go through examples. Sure.
What about like the knockoff names? You hear soft wave, stem wave. Is that all the same stuff? I mean, I'm sure it's...
Yeah, I mean, that's it kind of goes back to the same thing. Like, not all systems are the same. The reason we use what we use is because I think it provides the best outcomes for our patients, and it's shown. I think this isn't to disparage anybody that has these other things. I think there are certain things that tend to be a little bit better, and that's why we end up using them. I think the challenge with the soft wave components or some of these other things, it's almost like they try to combine everything into one device and then say, okay, this is like the radial and the focus. Or it provides such a wide area. I think somebody posted it on LinkedIn talking about the soft wave being like a paintbrush. We're treating the whole area. And I go, okay, in regenerative medicine, do you treat with a paintbrush? Do you treat with a paintbrush in regenerative medicine? No. Right? So that's kind of the way I look at it. Somebody else had a question. Yeah?
There were a couple supplements like BPC 157.
Yeah, I have no idea. I'm not your guy for that. I have no idea. I live in Boulder. There's tons of people that do. But I tell them if it's for anti-inflammatory reasons you're taking it, don't take it while we're doing treatment. Because this is all pro-inflammatory. I want good inflammation in there. Right? So that's why we don't do ice, we don't do NSAIDs, anything like that. Yeah.
So, like some of the machines, their thing is like, oh, you don't feel pain. You feel like pain is an important part of
Heck yeah. Right? Like, I tell them it should be intense but not painful. I want that like line right in between it. We push them. Oh, we don't baby feed them. Right? I mean, like, the whole premise is you're trying to get them ready to go. Yeah. If you don't feel anything, why don't you feel it? Because you're not injured there. Right? Or you don't know what you're doing.
But like some of the...
Or the intensity's not high enough.
Omni wave is like, oh, our thing is you don't feel pain.
Yeah, look, I'm not trying to disparage any like company or whatever. I'm just telling you, yes, you should, and like why you should feel it. have a reason to why you're doing this. I don't care about their pain. I do, but I don't. I want to hunt for why they have pain so we can get rid of that. Does that make sense? Right? That's why they're there. I told somebody out there, I go, what's a little more pain to get you out of the pain? You're already in pain. What does it matter? Right? We're trying to hunt to get you out. That's really big.
And diagnostically too, like I was saying earlier, you could, if you don't have ultrasound or anything, you just put it around and you go, okay, that's the exact spot they're having pain, then it's gotta be pathology.
Yep. So I mean, that's a really good point. I think, but that's the thing. It's about a mentality of how you go attack problems. I think, personally. That's what I tell my students. Right? Like I don't actually like hunting, but I like the analogy. Does that answer your question? Cool. All right. Let's go on. 28-year-old soccer player comes in with hip pain. And she's like, yeah, my hip hurts. I was like, okay. We check her, we put her leg in abduction, and she can't hold her leg up to gravity. 28 years old. That's a problem, right? No? Yes. Okay. It's right before lunch. I need you guys to stay with me, please, 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 right? I know it's hot in here, but like this'll be stuff that'll help you. So the big thing is she has a posterior SI ligament tear that we saw in ultrasound, and so we discussed Shockwave, EMTT, PRP with her. She actually didn't have enough adipose for me to take. These are instances where you end up using the PRP, and actually the PPP is the scaffolding. So we talked about it. She was like, nah, I don't really want to do it. We did the EMTT and Shockwave. And I was like, well, we'll do one in the office. We'll see what you think. 3 days later, she's like, I need to come back. I haven't felt so good in a long time. And it was her SI joint, right? We looked at her glute med, fine. It was actually her SI joint. This stuff gets missed a lot. Those guys that work in spine, you guys know this, right? I mean, like lumbar SI stuff, how much it's interrelated, kind of in that space. So we ended up doing PRP times 3. The reason, because I wanted to use the platelet poor plasma, which is high in fibrin, as a scaffolding that I would normally use in adipose. So if I had my pick, I would pick adipose and heartbeat. Here. I just couldn't do it because I couldn't get it from her. So that's the reason for the PPP. First PRP follow-up, she was like, I feel way better. I'm starting to feel more stable. And this is the 3-week follow-up, not after each injection. And so that's basically, she's getting better every single time. So pretty much, again, here, SI joint, major factor in hip pain, check for stability. How many people work on hips here? 1, 2, 3, 4, 5. What's the most common thing you guys work on? Oh, no, I mean, like which joint? Sorry. Knee? Knee? Is it knee? Yeah? Alright. So let's go with knee pain. 54-year-old amateur skier. He twists his knee skiing. I live in Colorado, so it's pretty common. That's why I don't ski, actually, because of this. I see a ton of injuries. So his knee exam is pretty normal, except for the effusion, and he's got some midline tenderness. So we talked about what to do here. We did a little bit, again, you look at EMTT, Shockwave, hyaluronic acid, PRP versus MFAT. Proceed with EMTT, and that's what we ended up doing. And the Shockwave on that medial joint line started to improve. And then he says 3 days later he went skiing, felt worse, and wanted to continue with the EMTT and Shockwave. So notice his pain with squatting. So what do you think he has now? Meniscus tear, right? So this McMurray test, I'm not really a big fan of. It is a buzzword insurance type of thing to get an MRI approved. If you want a quick and dirty way to see if somebody's got a meniscus tear, ask them to do this. Because if they can do this, what don't they have? A meniscus tear, right? If they do, they'll start to offload a little bit, or it'll be difficult to get that full flexion. If they can do that, they don't have a meniscus tear. What's the best way to heal this if you had a choice? And this is what Dr. DeWalt was saying.
It's hard.
Well, it's hard, right? So I would say when your family will call I'm gonna call your brother's doctor. So, what's the best way to heal this? So this is what I told him. 100 out of 100 times, EMTT, Shockwave, and MFAT. He said, all right, well, it costs too much. I'm gonna do physical therapy. Let's do the hyaluronic acid injection. We'll do a little bit of EMTT and Shockwave. So he felt better, certainly, but again, EMTT and Shockwave is not going to heal meniscus tear. Kind of get to the point somebody asked that earlier, like, what are you trying to do? Are you trying to heal it? Yeah, that's the goal, and improve function. That's what I was saying. So, this is why he asked again. So, what did you say was the best way to heal this? MFAT. So that's what we ended up doing. After the MFAT, we checked him 10-day just post follow-up just to check the incision sites, and then after 3 weeks, 70%. After 6 weeks, he was at 89%, and at 12 weeks post, he was 95% improved. I mean, like, really, at 3 weeks, he was 70% post procedure. So allow them to follow the path that they want, and again, this is why I talk about building relationships and making sure that everybody's sort of pulling in the same direction. Okay, so this is a different story. So you see, I like actually doing EMTT and Shockwave before we do an orthobiologic. I think it preps the area. I think it does really well. I don't really like doing it after, unless I have a time constraint. So this is a kid who was, a senior in college. He's a high-level gymnast, and he went snowboarding. He's got his national tournament in 10 weeks. So he's got a slap tear in his shoulder, so we don't really have very much time because he needs 4 weeks to train. So really I have 6 weeks. So if I go the traditional route, doing the Shockwave before and then PRP with him, then again, he's not gonna have time to train. So we did EMTT Shockwave that day. The next day we started a series of PRP injections. Again, why am I trying to do this? I'm trying to use the PPP as a glue-like substance for his labrum. I think PPP is actually underutilized. So we ended up doing this, and then, like I said, PRP and PPP. And then after, I gave him a week after his final injection to let it settle, and then I started doing some Shockwave up until his EMTT and Shockwave up until his tournament. So he competed, didn't have any pain. After his national tournament, he's like, I don't think I need surgery, actually. I don't know if I put this in there, but let's see. Oh yeah, here, this. So he called his coach, and then his coach called a former U.S. Olympic gymnastics team physician and told the athlete to get a steroid shot. And then to have surgery afterward. And I told him, I said, please don't let anybody do this to you. If you get a steroid shot, there's nothing I can do for you. Why? It's a potent anti-inflammatory. You guys know everything that we're doing is pro-inflammatory. That's a really old, archaic way of treating. I kind of get a little soapboxy, but I'm going to explain why. If you think about ice, NSAIDs, steroid injection, are you treating the actual cause, or are you treating symptoms? Symptoms. I already told you I don't care about your pain. I'm trying to figure out why you have it, so we can get you out of it. That's not healing. What is healing? EMTT, Shockwave, PRP, adipose, all that stuff, right? You want to give them something for pain? Tylenol. That's it. But there's got to be buy-in, though. I mean, that's the thing, right? I can't just say it, and then people are like, well, you know, I tell them, like, if you want to walk out of here and say Garg's crazy, I'm like, fine, I'm okay, you'll be okay, but I just may not be the guy for you. And you got to be okay saying that too, right? You will inherently not be able to please everyone. Somebody in this audience will be like, this guy's a terrible speaker, he's arrogant, whatever. And I'm like, okay, I'm trying to connect and make sure you guys stay with me here. Okay? That's a big thing. So I just thought this might be helpful. I asked my staff to put this together, areas treated, and we do a ton of hip work. A ton, because it gets missed a lot. So people come in and they're like, I don't know, my back hurts, and it's actually not their back, it's their SI joint, or I don't understand why I keep getting recurrent lower extremity problems. My knee hurts, my ankle hurts, my foot hurts on the right side. Well, that's probably your SI joint or your glute med is thickened, so whatever. But this is kind of a depiction of who we treat. And then just the different types of tips. This is a more superficial tip. This ends up being a little bit deeper. And then these two are for the radial, and then this is with no standoff for the focus. So these are just a distribution. The S0 would be like if you're trying to get into a femoral neck stress fracture, right? Because I'm trying to go deep into that bone. So you use the S0. So much so that we actually have a training institute that we have started because just having the machines isn't enough. I think that's the other component, that if you end up getting the machines, then they're like, okay, now what? Like, patients should just be rolling in, right? I got the machines, we're good. I don't know how to use them, right? I think there's really good evidence for it. There's really good research that this stuff works, but there's a dearth of actual training. And so I've had a lot of people say, hey, can we come to Boulder, and can we learn, and can you take us through it? So that's what we've sort of created. So if you guys go on LinkedIn, you'll see it. Just search for that. Questions so far?
Expound on PPP plus PRP, how you're choosing when to do both.
Yeah,
Technique,
I actually,
volume.
yeah, so the question's about PRP and PPP and why I use it. So what I do is actually lay down a little bit of the PPP and let it sit there for a sec, where it acts like a fibrin glue, right? And so, and then I lay the PRP where I want it to be, and for me, it seems like it ends up just sticking in there pretty well. Jeff talked about the sticky factors of PRP and all that, which is accurate, and there's also growth factors in that PPP, but I think if you're separating them out and laying them in different areas, because think about it, if you mix it, what is it? It's just diluted PRP, right? But what we're doing is we're separating it out and targeting those areas where it's almost like a sealant, and then you lay the PRP on top.
Couple examples. That's good. Examples when you would use those together.
I use them all the time. Yeah, there's not a spot where I don't use it. Yeah.
You do the PPP, and then how long do you wait before you do the PRP?
Yeah, so I mean, it's just a few seconds. I mean, this
Oh,
isn't
literally.
yeah.
Okay.
This isn't like you're going to have a sandwich and coming back. Yeah, it's like, but again, it's laying it down in that way, using the ultrasound, making sure you're targeting where you want to be, right? That's really big thing. Yep.
So in this 21-year-old athlete with a slap tear, obviously his shoulder's going to be important. How did you take me through how you did the treatment? Like,
Oh yeah, like how did I do the injections?
Yeah, no,
Yeah.
just like how, yeah, exactly. How did you do that? Are you getting on top of the glenoid and in between the labrum and the glenoid severely and injecting that sticky stuff?
Yeah, I'm actually going anteriorly.
Okay.
So I'm going anteriorly, right in the joint space, and so what I'm targeting is trying to blanket and coat that anterior labrum. And then we did it posteriorly as well, where we flooded it with PPP on the posterior side. So that's what we're trying to do. I actually hit like 4 different spots, angling, trying to actually get as much into that labrum as I could, and also going posterior. That's a great question.
Now, you just want as a follow-up.
Yeah.
Because he's a high-level athlete, are you getting an MRI afterwards? Like, even though he's symptomatically better,
Uh-huh.
are you confident it's healed, or are you getting an MRI to factor?
Great
that?
question. So my students ask this all the time. How does it change your management? If it's for simple curiosity, that's not a good enough reason to get imaging.
With
The
that,
kid's better. The kid's doing stuff, right? And if he's hurting at a certain point, then we say, yeah, let's get a repeat. If I wanted to do research or whatever, then yeah, you get a repeat MRI and you do a case study and you do all that. Fine. But yeah, in that situation, unless for me it's warranted, I don't see a point to it, right?
with that patient choosing MFAT, was it just too traumatic because you're too close, or you didn't want to use MFAT in terms of more?
Who's that?
The slap tear.
Oh, he's a gymnast. There's no fat on him.
I was gonna say, or is it just there's no fat?
There's no fat on it. Yeah,
Okay.
I would love to do fat.
Okay, all right.
Yeah, sometimes I
Okay.
can't, right? And then if
Yeah.
I can't,
That's
then I
okay,
end up
because-
doing, then I do the PRP times 3 because I'm using, it's really for the PPP.
Yeah.
I mean, obviously you get added benefit for using the PRP, but it's really more for the PRP.
Yeah.
It's a PPP, sorry.
Oh, yeah.
Yep, the fibrin-rich plasma, if you want to call it.